Good evening and welcome to the October 2025 edition of Glaucoma Australia's live Q&A webinar series, which is proudly brought to you by our long-standing and very generous supporters, Glaucos. My name is Val Toswell and I'm one of the 3 orthoptist patient educators here at Glaucoma Australia, as well as your host for this evening. Before I introduce tonight's guest speaker, I'd like to acknowledge the traditional custodians of the lands, skies and seas in which we collectively gather for tonight's event. I pay my respects to our elders past and present, along with their emerging leaders. Tonight's presentation is Seeing Ahead, Advancements in Glaucoma Care. It's a really exciting time in glaucoma management with recent innovations, and I'm sure that you're going to get a lot from tonight's presentation. During this session, Dr. Kate Hogden will explore some of the emerging advancements in glaucoma care, including diagnostics and treatment options. Dr. Hogden practices comprehensive ophthalmology with subspecialty interests in glaucoma, cataract surgery, and medical retina. Dr. Hogden completed her medical degree at the University of Queensland before moving to Sydney to undertake ophthalmology training at the Sydney Eye Hospital. She then completed subspecialty training in glaucoma at the surgically renowned University of British Columbia, UBC, in Vancouver, Canada, for which she was awarded a Ramsco Topham Scholarship. Whilst at UBC, Dr. Hogden also spent time with the prestigious vitreoretinal department, gaining invaluable medical and surgical retina experience. More recently, she supplemented this with further medical retina training locally at Sydney Eye Hospital. Dr. Hogden performs various glaucoma laser procedures as well as traditional glaucoma surgeries, including trabeculectomy and glaucoma drainage devices. She also has a special interest in minimally invasive glaucoma surgeries, and I'm sure a lot of you know the term MIGS. Dr. Hogden holds a public appointment at the Royal Brisbane and Women's Hospital and enjoys being involved in registrar training. She's actively involved in ongoing clinical research and has presented at a number of Australian and international ophthalmology conferences. Thank you, Kate. Over to you.
Thank you, Val. Sorry, I'll just get this up. 1 second.
It always works so easily when we
that's it.
Through.
So hopefully that's sharing now.
That's great. Thanks, Kate.
Can you see that, Val?
Yes,
thank you very much for those kind words, and thank you for Glaucoma Australia for inviting me along tonight. So as Val said, my talk is entitled Seeing Ahead, Advancements in Glaucoma Care. So, you know, it really is a very exciting time in ophthalmology and glaucoma care in particular, because there are a lot of innovations in terms of treatment options, which will hopefully improve the options we've got available to manage the condition, and ultimately improve our quality of life. So hopefully everyone's comfortable. We'll be talking about innovations in glaucoma medications, lasers, and surgical treatment options. So this is quite a broad topic, so we'll just be looking at a few options within each of these different categories. So talking first about glaucoma medications and some of the latest innovations in this area. So medications for glaucoma include those that reduce the intraocular pressure, and that certainly is the mainstay of glaucoma care at the present time. So we'll be touching on some of the newest drops in this area. We'll also be looking at some of the newer types of drug delivery systems, as well as some of the newer medications looking at optic nerve neuroprotection that are independent of reducing the intraocular pressure. So looking first at medications that reduce the intraocular pressure, we'll be talking about latanoprost bunod, otherwise known as Vyzulta, the Rho kinase inhibitor medications, and as well as a new trial medication that is in investigation called NCX 470. So looking first at latanoprostbulinode or Vyzulta. So this is a prostaglandin analog medication, which many of you may be familiar with. This includes medications like latanoprost, otherwise known as Xalatan. Lumigan is another commonly used prostaglandin analog. So Vyzulta is similar to these medications. It has a latanoprost acid moiety, which helps to increase the outflow of the aqueous fluid through the uveoscleral outflow. It also has a novel nitrous oxide donator, which increases trabecular meshwork outflow through the conventional pathway of the eye, and in this way it provides additional intraocular pressure reduction. So this medication is administered once daily. So studies of this medication looked at comparing the Vyzulta versus latanoprost alone, and they found that this new medication gave a average pressure reduction of 1.2 millimeters of mercury on top of latanoprost alone. Moving forward to the Rho kinase inhibitors, so some of you might be familiar with this. One of these medications is Rhopressa. So these medications work to inhibit the Rho kinase enzyme and also a neuroepinephrine transporter, which increases the aqueous outflow and again lowers the intraocular pressure. This medication is administered twice a day, and it's shown to be quite efficient in reducing the intraocular pressure by 3.5 millimeters at trough and 4.5 millimeters at mercury at the peak. So that's 2 hours after instillation. So NCX 470, so this is similar to Vyzulta, so it combines a prostaglandin analog plus nitric oxide to aim to achieve a lower intraocular pressure. So the difference with Vyzulta is that the prostaglandin component is bimatoprost, and so that's the same medication as, or similar to Lumigan. So the trials that have looked at this study are the Mont Blanc trial, and that showed that the medication was non-inferior to latanoprost or Xalatan. So that's promising, and hopefully we'll have further results of that in the coming years. Looking at drug delivery systems, so we know that it can be quite taxing and in some cases difficult to administer glaucoma topical drops. We know that medication compliance can be a significant challenge, and unfortunately there are varying ranges in terms of patient compliance with the medications, and that can range between 5 to 80%. Unfortunately, we know that not using the drops is associated with progression of glaucomatous field loss. So this really has encouraged the development of different drug delivery systems to try to help lower the intraocular pressure of the eye. So one such medication is the bimatoprost implant, otherwise known as Durysta. So this is a biodegradable polymer that's injected into the anterior chamber using a 28 gauge pre-filled applicator that you can see here in the top right-hand corner. And you can see a photograph here in the bottom right of that device just resting in the front of the eye in the anterior chamber. So over time, this polymer disintegrates. It gives a duration of effect of 3 to 4 months. The trials looking at this study show that it was non-inferior to timolol, which is another common medication used to treat glaucoma. It also significantly showed that there were no adverse side effects of the medication. So typically with the topical prostaglandin analogs, which is what bimatoprost is, we often see lash growth, and sometimes the skin surrounding the eyes can become pigmented, and sometimes they can become a little bit thin as well. So in this trial, it showed that there were no such changes noted with this implant. One thing of concern that will need further follow-up is sometimes they did see that there was increased what we call corneal endothelial cell loss. So that will be an area that needs ongoing refinement. Another emerging drug delivery system is iDose TR. So this is a travoprost intracameral implant. So a similar idea to what we just spoke about with Durysta. So it's a biocompatible titanium implant reservoir. This time, instead of being just injected into the anterior chamber, it's kind of placed in the anterior chamber angle, as you can see in the photograph here. It then has a special membrane that allows the medication to slowly elute with time. So studies have shown good pressure control out to 3 years with this device. So 63% of patients demonstrated well-controlled intraocular pressure with the same or fewer number of topical glaucoma medications. A more recent study looked at this medication, and it showed that for the first 3 months, there was a nice improvement in the intraocular pressure compared to timolols, which again is one of the commonly used medications to control intraocular pressure, and that it was certainly, equivalent to timolol out to 3 months. Other drug delivery systems, so there have been quite a few that are being explored. So that includes the bimatoprost ocular ring, which you can see in the top right here. So this is a silicon ring that's impregnated with bimatoprost that sits between the upper and lower fornices of the eyelids. So its aim is to stay there for 6 months, and it slowly releases the medication over that period of time. Contact lenses with micellar-laddered medications are also being explored, as well as travoprost punctal plugs. And that's demonstrated in the bottom right here. So these are hydrogel rods that are impregnated with the medication. And again, the idea is that the medication is then slowly eluted over the next 90 days. So these are, interesting ideas that may help to reduce the burden of having to place topical drops on the eye for the pressure control. Just deviating slightly now, I just wanted to talk about the concept of precision medicine. So we know that the pathophysiology of glaucoma is complex, and it's a multifactorial disease. We do know that the common endpoint is retinal ganglion cell death. So that's death of the cells that make up the optic nerve. There's multiple upstream pathways of this, including oxidative stress, mitochondrial dysfunction, neuroinflammation, and vascular dysregulation. So currently, as I said, the mainstay of treatment at the moment is to lower the intraocular pressure, but that doesn't really target these upstream drivers of that disease process. So there's lots of active research at the moment looking at certain medications that target these drivers of the retinal ganglion cell death. So hopefully, as we understand more in terms of the pathophysiology, we'll be able to tailor the treatment for depending on the different subtypes of glaucoma. So what we'll talk about next is the evolution of neuroprotection in glaucoma treatment. So there are quite a few compounds that are being investigated in terms of their role of protecting the optic nerve independent of lowering the intraocular pressure. And we'll just be talking about a few of them tonight. So ginkgo biloba, so some of you might be familiar with this. This has antioxidant properties as well as vasodilatory effects, which potentially can increase the flow of blood to the optic nerve. And small studies have demonstrated positive effects of this medication in normal tension glaucoma. Another compound is resveratrol. So this is found in grapes, peanuts, and berries. Again, this has antioxidant, anti-inflammatory effects and improves mitochondrial function and optic nerve flow. The studies at the moment are looking promising, however, they're still preclinical, and so they're animal models. Curcumin is another compound that's being explored. So this is an active component of turmeric, where probably many of you may be aware of its antioxidant and anti-inflammatory effects, and it's also got other neuroprotective effects independent of lowering the intraocular pressure. Currently, the bioavailability of curcumin is challenging, so they're trying to develop curcumin nanoparticles and potentially eye drops that may be useful in glaucoma care. Other novel neuroprotective agents that are being explored include NMDA receptor antagonists. So the mechanisms of these are to prevent the excitotoxicity that's involved in retinal ganglion cell death and in glaucoma. The Rho kinase inhibitors, which we spoke about before, because we know that they lower the intraocular pressure. There's also thought that they may promote retinal ganglion cell survival. Cetirizine is an endogenous compound that's involved in phospholipid synthesis. This is thought to enhance mitochondrial function and reduce oxidative stress, which may also be beneficial. There's been studies showing improvements in visual function in patients who are administered oral doses of cetirizine. Cannabinoids, many of you are probably familiar with, so these have the ability to reduce the intraocular pressure and potentially provide neuroprotection as well. Probably lastly, but certainly not leastly, is vitamin B3. So I think this certainly is an area, and this compound in particular, is certainly looking promising. So results from this come from the Centre for Eye Research in Australia. So vitamin B3 is the precursor to nicotinamide adenine dinucleotide, or NAD+, which is a very important component in energy and redox metabolism. So we know that as we get older, NAD+ is depleted in eyes in the cells, in cells in the eye, and this makes them more vulnerable to disease. We also know that in patients with glaucoma, we found that NAD+ is they're associated with lower levels of NAD in the aqueous humor, which is the fluid in the front of the eye and also in the peripheral bloodstream. So the thought is that if we increase vitamin B3, that this may then increase the levels of NAD and make those retinal ganglion cells less susceptible to damage. So there was a study in Australia, as I said, that was published a few years ago showing potential protection and slowing of retinal ganglion cell death. And there's further research being conducted at the moment in Moorfields, which is one of the big eye hospitals in the UK. So they're looking at recruiting over 500 patients to have a look at the effects of oral administration of vitamin B3 in the progression of glaucoma. So hopefully we'll have some more results and evidence for that medication emerging in the next few years. Moving on now to glaucoma lasers. So we'll talk about selective laser trabeculoplasty, repeat SLT, direct SLT, and a novel and a laser treatment called FLIGHT. So selective laser trabeculoplasty is quite a common treatment for open-angle glaucoma and ocular hypertension. There was a recent study published a few years ago, which was one of the largest randomized controlled trials looking at administration of selective laser trabeculoplasty, first topical drops in patients with newly diagnosed open-angle glaucoma or ocular hypertension. So the results provides really good evidence for us of the benefits of SLT. So patients in the SLT treatment arm had better glaucoma symptom scale scores than those patients who received topical therapy. Nearly 70% of patients in the SLT cohort remained at or less than their target intraocular pressure without the need for medical or surgical treatment. There was less progression in the SLT treatment arm than the drop arm, which is demonstrated in the top right graph there. And surgical intervention was required in less eyes in the SLT arm than in the arm that received topical drops. It also demonstrated the safety of the treatment as well, which obviously is very important. So more and more, we certainly are utilizing selective laser trabeculoplasty early in the treatment algorithm, which is quite beneficial because then it often minimizes the need for topical glaucoma drops. Questions still remain, however, so we've been using SLT for quite some time now, but there still is some uncertainty in terms of how often we can repeat the treatment and also potentially the most effective kind of protocols for energy application during the treatment. So looking further at this and in terms of trying to answer some of those questions is the analysis of the Light China study, which was recently published. So in this trial, patients were treated with standard SLT as first-line therapy. If then patients needed escalation of their treatment, they were then given a second round of SLT, and that was irrespective of whether they had a response to the treatment in the first instance or not. So the results of this study have again been positive in terms of SLT. So with the initial round of SLT, they found a mean intraocular pressure improvement of 4.5 millimeters of mercury. And then when it was subsequently repeated a second time, they found a mean intraocular pressure reduction of 3.3. So it does provide us with evidence that even with the second round of treatment, there is support for using SLT again, even potentially in those patients who may not have had a benefit the first time round. Looking further at trying to potentially optimize the way we use SLT is the COAST trials. So the premise of this group of studies is using lower energy selective laser trabeculoplasty, but repeating that more frequently, and to see whether how that improves the intraocular pressure. So the premise for this collection of studies is a trial or a paper that was published from a university in Italy, where they performed low energy selective laser trabeculoplasty annually. And they found that they had a sustained intraocular pressure reduction and a fewer use of additional topical glaucoma medications. So when we normally do conventional selective laser trabeculoplasty, we're treating the trabecular meshwork in the eye, and the end point is seeing what we call champagne bubbles, and that typically is at an energy of about 0.7 millijoules. So just to demonstrate that in the newer algorithm proposed in this COAST collection of studies, we're using much lower delivery of energy of about 0.4 millijoules. So it is certainly an exciting idea, and potentially given the ability to repeat this laser more frequently and provide longevity of the pressure control before we potentially need to add in additional topical drops. So direct SLT is a similar laser as the conventional SLT, which is what we just spoke about. So as you can see in the bottom in this diagram here, so conventional SLT, which some of you may have had, involves applying a gonioprism to the front of the eye so we can visualize the trabecular meshwork. With direct SLT, it's a contactless procedure that automatically delivers the laser energy. So this allows us to potentially use it in both patients with open angle glaucoma as well as angle closure. And the 1-year results do show an improvement in the intraocular pressure in both patients with open and closed angle glaucoma. Looking now at flight, so this is a novel non-invasive glaucoma procedure using femtosecond laser image-guided high-precision trabeculotomy. So what this laser involves is creating tiny little channels or openings in the trabecular meshwork into what's called Schlemm's canal, and basically that creates an alternate part or augments the natural drainage of fluid out of the natural drainage pathway of the eye. In the studies looking at this, they've had results out to 2 years. They showed the mean intraocular pressure was reduced by nearly 35%. So that's certainly an interesting procedure that's showing promising results so far. So it's another area that we'll just have to wait and see what further clinical trials what evidence is provided for the ongoing use of this. Turning now to talk about some of the developments in the glaucoma surgeries, we'll talk about some of the various devices available, including the Miniject, minimally invasive bleb surgery, including PreserFlow, and as well as touching on another device called the VividFlow, angle-based surgery developments, as well as regenerative and gene therapies. So the mini Jack, so this is a device which is implanted in the front of the eye. So it drains to the supraciliary space. So you can see that in the diagram down here. So the device is sitting kind of in the anterior chamber angle then. So it's a 5 millimeters in length. It's composed of a biocompatible silicon, which has a porous design, as you can see here. And the idea of this is that it encourages more fluid to flow out, and it also minimizes fibrosis and scarring with the surrounding tissues. So this device is inserted via what's called an ab interno approach by making a small incision in the front of the eye. So we've got 2-year data that's been published looking at this device, and it's shown a nice reduction in the intraocular pressure out to 2 years of approximately 39%. As with all devices, there are some complications, and included in this includes bleeding, and patients there have been cases where there's been anterior chamber inflammation. So the PreserFlow microshunt is a more recent development that is being used quite commonly throughout Australia. So this is an 8.5 millimeter device that's composed of a special compound called SIBS. It's quite clever in how it's been designed. So it's designed according to the Hagen-Paswell principles. And the idea of this is to minimize the pressure from going too low in the eye at the rate at which the fluid in the eye, the aqueous, is normally produced. Again, this device it's slightly different to the mini Jack, which we just spoke about. So when we use this device, we create a little pocket on the outside of the eye. So we make a pocket in what's called the conjunctiva. We place the device, what's called ab externo. So the device then we insert into the front of the eye, the anterior chamber, with the distal tip resting in the little pocket which we created. So that then allows fluid to flow from inside the eye to up underneath the conjunctiva. And so it creates what we call a bleb. So when we look at results, again, out to 2 years, so in one of the pivotal trials, the baseline intraocular pressure for the patients was a mean of 21.7 millimeters of mercury. At year 1, they found the mean was 14.5, and this reduction was sustained up to 2 years. So it's showing a really good improvement in intraocular pressure control. Also, they found that nearly 75% of patients were medication-free at 2 years. So again, it's a really good addition to our glaucoma toolbox, and another option to try to reduce the burden of some of those topical glaucoma drops. I just wanted to touch on a device that is currently in trials. So it's called the Vivid Flow implant. So it's another Australian design. It's being researched at the Centre for Eye Research down in Melbourne. So it's a microsive leaf shape device of flexible silicon. So again, it's inserted into the front of the eye, and it's then sits up underneath the eyelid, underneath the conjunctiva. And you can see here, so the fluid flows up along these pathways, and then there's many different channels that enables that fluid to drain out of the eye. So hopefully we'll have some further information regarding the efficacy of this device in the coming years as that study progresses. Angle-based surgeries have certainly revolutionized glaucoma care in the last 10 years, and this is certainly an area of ongoing innovation. So there are improved canaloplasty techniques. So this is where we kind of cannulate what's called Schlemm's canal. So it's one of the anatomical features of the drainage angle, and just try to enable more fluid to flow out of the natural drainage pathway of the eye. So there's the VIA 360, which provides a new way of vascodilating Schlemm's canal and the downstream collector channels. We've also got the Omni and eye track available as well. There's further research looking into newer devices and innovative materials that provide better biocompatibility and integration. Also, again, just touching on precision medicine. So I think the biggest challenge with lots of glaucoma surgeries is trying to ascertain and make a judgment as to what surgery is going to be most effective for the patient in front of us. And so with the use of biomarkers, imaging, and artificial intelligence tools, hopefully in the future we'll be able to better predict and tailor patient care depending on their particular type of glaucoma and their phenotype. So that certainly it will be very helpful innovation in the years to come. Just briefly, I wanted to touch on gene therapy. So gene therapy is a really promising frontier for glaucoma care because hopefully it'll target those upstream processes that are involved in the retinal ganglion cell death, as we talked about at the start of the presentation. As I said, so, glaucoma is multifactorial, which makes it really challenging to treat this condition. And unfortunately, we don't completely understanding all of the pathophysiology of it. So some of you might be aware of some retinal conditions that are treated with gene therapies, but it's been a little bit slower to develop those in glaucoma because of the complexity of the nature of the complexity of the disease. So it is an area, though, that is being explored, so the different gene therapy strategies, and so some of those are directed at trying to reduce the intraocular pressure, and there are other gene therapy strategies looking, again, at the neuroprotection, which is what we spoke about before. So this is really a very exciting area. Artificial intelligence, I think, will also continue to have an increasing role in glaucoma care, and that'll include from the diagnostics and screening, as well as predicting progression, and again, also a role in treatment planning. So thank you very much. Hopefully that has helped to provide some information of some of the newer advancements and future avenues in glaucoma care.
Thank you, Kate. That was a fantastic overview of the innovations and clinical trials surrounding glaucoma. As patient educators, we receive a lot of questions around current and future treatment trends. So your presentation is very valuable. Thank you. If the audience do have questions for Dr. Hogden, please add them into the comments. And we've received a few questions already, with the first one from Anthony. I've been diagnosed with glaucoma and I'm 62 years old. I am type 2 diabetic and obese. I'm thinking about having obesity surgery, but I don't know if it would be bad for my glaucoma because by shortening the path of food through the intestine, I would absorb fewer vitamins and antioxidants, which would need to be supplemented. What is your opinion on this?
Yeah, I think, thank you, Val. I think that's a really good question. I think, and I don't know the specifics of everything here, but I think there's certainly lots of benefits for trying to, achieve a healthy BMI, and that can improve the, our cardiovascular risks as well, and improve oxygenation throughout the body, including the eye, and that certainly can be beneficial for the optic nerve as well. So, and that can also help with diabetic control as well. There are other risks associated with higher BMIs as well, such as sleep apnea, which we know, particularly in normal tension glaucoma, can be a really significant risk factor. So I think there are so many benefits that can be achieved, with maintaining a healthy body weight. And I would think that they outweigh, some of those concerns in terms of potential malabsorption with, any weight loss surgery.
Great, thank you. Another question from Marilyn. I have 4 stents in each eye. Is it safe to use earbuds that have magnets for TV watching and using a tablet?
Yeah, fortunately, they are safe. So you'd be fine to use earbuds while doing those activities. The eye stents also are MRI compatible. So there are various different kind of strengths of the magnets. Most of them are up to 3T, so eye stents are compatible for up to 3T, but not 4T MRIs. So in most instances, they're safe, but you just need to check exactly what the specifics of the MRI, if you were having imaging performed.
Okay, great question. Thank you. Mark has mentioned, I have a yearly appointment with an eye specialist to keep things in check. My specialist said I have the very, very, very early signs of glaucoma because my dad suffered badly from it. At the moment, I have daily drops to keep the pressures under control. How do you see this treatment changing in the next 5 years?
I mean, I think more and more, we're using probably the way that I'd see that, probably going in the next 5 years is just the increasing uptake of selective laser trabeculoplasty. So as I said, often we are using that more and more as first line, and it does negate some of the side effects that can happen with the topical drops. So probably I see that there'll be more use of the SLT. There are those various devices, as we touched on, so Durista and also the travoprost implant from Glaucos. So it'll be interesting to see what comes with those, but they're certainly promising as well. I guess also not knowing Mark's specific case, but certainly with the advent of the minimally invasive glaucoma surgeries, we're also often intervening a little bit earlier, particularly in patients who may have cataracts, and combining that surgery with stents, which can help to alleviate the need for some of those drops again.
That's great. And we get a lot of questions about drops and the complications and side effects from those. So treatments that can lead towards not needing drops, terrific.
Yeah.
We have a question from Eye Sociology. Looking to the future, might low energy SLT have a particular application for longer term treatment of juvenile ocular hypertension or JOAG?
Yeah, I mean, I guess the benefits, I think we'll need to wait and see what comes with the COAST trials to have a look at, it is a bit of a change, that lower energy SLT treatment. Juvenile open-angle glaucoma often, have quite high pressures to begin with. And certainly SLT, again, does have a very good role there. So we'll just need to wait and see, what the evidence is for those, lower, more frequently repeated treatments of the SLT.
Yeah. Thank you. We have a question from Dungannon. Will any of these new treatments be available in Australia soon? That's a great question.
Yeah, I think probably the ones to look at would be the Durista, the Mataprost implant, and also the Glaucos option there as well. Certainly the rings, like the silicon Bimatoprost ring, that's kind of been, some of those have been around for a little bit of time, but there are issues in terms of the retention, same with the travoprost plugs, but they are, certainly, areas that are being explored to try to improve it, to make it something that is actually, could be used functionally for patients to try to alleviate the need for the drops.
Yeah. Thank you. So question from Martin Ellis. The flight trial sounded promising. Where is this trial being run? And do we know when the results will be available?
I think it's being run in the States, and my understanding is that there was a smaller trial that was published, which I spoke about during the presentation there. But as with all, before anything's kind of implemented, clinically, like in day-to-day practice, it does require quite vigorous testing. So I'd imagine that that's going to be a little bit of time off. But it is, a really interesting idea. So, it'll be good to see, to follow that along, to see what other studies, larger, kind of higher powered studies show, demonstrating the efficacy of that.
Yeah, and as we know, clinical trials can take a good 10 years from start to finish with following them all through. We have time for one more question from Yannicka Senevaratni. How does one get involved in these clinical trials?
It depends. I mean, usually some of the larger hospitals are involved with them. I know at Sydney Eye there was often various studies running. Val, you might know with Glaucoma Australia what clinical trials are currently running, and often then it's a matter of just assessing the suitability to be included in that trial.
Yes, yeah, it's very strict inclusion exclusion criteria for a clinical trial, so your ophthalmologist needs to be involved in that as well. Yeah, thank you. Unfortunately, we don't have time for any more questions, so if you do have a question that wasn't able to be answered, can you please direct them to us at glaucoma@glaucoma.org.au, or you can phone us on 1800 500 880 and we'll forward to Kate for her response. Thank you again, Kate, for this fabulous presentation, and thank you to everyone who joined this live webinar tonight. And the webinar will also be available on Glaucoma Australia's YouTube channel, and that's easily accessed at the bottom of our GA website homepage. So thank you, Kate. Thank you for everyone for joining in, and enjoy the rest of your evening. Thank you.
Thank you.